Thank everyone for joining us for the first of the new program year Safety Council meeting for the Marion Area Safety Council. I'm assuming that you being here means you probably saw the email where we kind of broke down why we're here still virtually and what that'll mean for the rest of the year. So again, if you hadn't seen that, it was out of our hands to a certain degree. The BWC made the announcement that this year would continue to be a virtual program year that'll run through the end of June of next year. So we will continue to meet like this, not collecting any attendance per se for these meetings, and unfortunately without the rebates that might be attached to them for this program year. But we hope that we put together some amazing speakers and programs for you regardless. I want to thank again our steering committee and Tanya Boffman here for putting together some awesome presentations for you. And that starts of course with this month. We're very happy to have Brad DeCamp, Executive Director of the Crawford Marion County ADAMH Board, here to talk to us today about mental health still matters in the workplace. With nearly 1 in 5 U.S. adults experience mental illness each year. However, a recent survey indicated 40% of U.S. adults have reported adverse mental health conditions as a result of COVID-19. This includes depression, trauma, stress-related disorders, substance abuse, and suicidal ideation. The workplace can be a key location for activities designed to improve the safety and well-being of adults. And in this presentation, we'll be reviewing mental health conditions, relevant statistics, strategies employers can support and to promote employee wellness and resilience as part of a healthy and safe workplace. Before we get into the presentation with Brad, one quick announcement. Later on, I believe this week, we'll be sharing with you that the Lacey Award, which took a little bit of a break for this during COVID times when it was very difficult for us to be able to get out to facilities to go through the inspection piece of it, will be occurring again with the announcement, I think coming in October, I think is when we've set on. So the announcement for the application and submitting for those applications will start here very soon. I think as early as next week. We'll start accepting those. So very happy to be able to have that back. A very important and prestigious safety award will again be hosted here in our community. And before we get into the presentation today, I think Laura from our BWC rep has a couple of announcements.
Yeah, hi everybody. July, new policy year. Kind of crazy to think we have gone an entire year without seeing anybody besides through our little screens. So just quick updates. The BWC, our COVID-19 Indoor Air Quality Assistance Program, that has actually been extended until December 31st of this year. So if you are an eligible facility, make sure that you get your applications in. We definitely want to be able to assist you with your air quality. Kind of fitting with what today's topic is, our BWC blog. We actually have a suicide prevention blog, and it's actually Too Tough to Talk, Suicide Prevention and Construction Program. Typically, we tend to think construction workers are rough and tough and they can't talk about their mental health problems. So we need to get rid of that stigma, and hopefully today's presentation will assist with that. But we do have a blog currently up on suicide prevention, as well as we have some heat stress training available. Even though it's been rainy, we know it's been really humid and hot, and so we really want to make sure that we are protecting our workers and letting them acclimate to the heat of Ohio summers. In OSHA news, there is still new OSHA COVID-19 guidance out there. There is a new emergency temporary standard for healthcare, and then there's also information out directly about what you guys need to do, what the compliance officers are going to be looking at when they come into your facilities regarding COVID-19. So all that information is out there on OSHA's web. Also, there is a new first aid for heat illness poster. Again, OSHA is promoting heat awareness, heat stress awareness. So there's some information on OSHA's website on that. And then also there is a new distracted driving dashboard from the Ohio State Patrol. It's pretty awesome. I looked at it the other day, and actually since 2016, there's been over 70,000 crashes in Ohio attributed to distracted driving. And that's not just texting and driving. drinking our coffee, eating our sandwiches, thinking is the distracted driving. And I don't know about you guys, but how many times have you gotten in your car, gotten to your destination, and then thought, how did I even get here? You know, subconsciously, we just drove. So there's a dashboard out there that you can see. There's actually a video from Richland County I watched. It took a driver of a truck 1 minute and 8 seconds to realize that there was a state patrolman behind them, flagging him down, like telling him to pull over. It took him 1 minute and 8 seconds to actually pull over. So that's kind of crazy. And then also from NIOSH and the CDC, there is in-vehicle monitoring systems that can go into your work fleet vehicles to help employees identify risky driving behaviors. That way you can prevent those distracted driving situations in your fleet vehicles. But I will send Matt a PDF with a presentation I have so you guys can see all that I just talked about. And if you guys have any questions, please reach out. The BWC, we're still currently reviewing how we're going to do business. Obviously, going forward, we're still going to incorporate virtual, but we are looking at how and when we can come on site. But just understand that we are looking into that. So as of right now, today, if you needed my assistance, it would be virtual, but we are here to help you guys out. So always reach out to us with any questions that you might have. And with that, I'll pass it back to Matt.
Thank you, Laura. And I was remiss. We did have one announcement that Thad Scherer wanted to make from Poet really quick before we get into this.
Thank you, Matt. Appreciate it. Good morning, everybody. As part of the local emergency planning committee here at Poet, we do manufacture highly flammable liquid, and you guys use it in your gas tanks. But we also have some other hazardous chemicals on site that the fire department would like to be aware of in the event that they're responding to any kind of a fire at our facility. They would like to know where these liquids or these materials are located, and that's part of our Tier 2 reporting that we submit every year. Just wanted to bring that to everybody's attention. EPA has a list of lists out there for us to review. All of these chemicals, a lot of them, it's a 10,000 pound limit reporting threshold. So if you meet that threshold or above that threshold, you have to report. But based on the severity of some chemicals, it might be a lot less. And I bring this up. The LEPC meets every other month. And basically it exists to protect the community from events that involve chemical releases at operating manufacturing facilities, right? And so if your facility does have a Tier 2 report that they submit annually, or if you're unaware, you do have some larger quantities of some hazardous chemicals on site or extremely hazardous chemicals, and you're not sure about the threshold, you can easily find the list of lists on the EPA website or just do a Google search. But we're looking for companies so we can have training opportunities and training. They're here to protect the community and us in the events of the catastrophic event. So it's our responsibility to report, make sure everybody's aware, make sure the local emergency planning committee is aware. And I just want to encourage you guys to be a part of that. Just like Matt said, this is the first meeting for this season. Our first meeting for the next season of LEPC begins in August. So therefore, we'd like to just, if you want to be involved with the LEPC and you haven't been yet, feel free to message me. Just click the little menu up beside my name and send me a quick message during this meeting, and message me your email. I'll put you on a list, and I'll touch base with you outside of this. That's all I have. Thanks, Matt.
No problem with that. And for those that are watching the recording of this afterwards, and those that are on this call that want to reach out to Thad, we'll also provide Thad's contact information in our email that will go out to everyone after this meeting's concluded. All right, Brad, no further ado, I will hand it over to you for the rest of the presentation.
Thank you, Matt. And I do apologize to everyone. I feel like I'm in failure mode effect analysis. For those of you who work in the QI world, I had tried to get this from my tablet to my laptop because I'm having trouble with Zoom on my tablet, and tried to get a flash drive. The flash drive wouldn't work. I tried to send it to an alternative email. So I ended up having to send it to Matt. So thank you, Matt, for receiving that. And I do appreciate everyone's patience. So we'll go ahead and move on. I want to talk about mental health still being important and needing to be talked about in the workplace. So we can move forward, Matt, if you're ready. We can go on to the next slide real quickly. Matt did introduce me and read the intro, so I won't waste a lot of time on that. I did want to take a minute, though, and just go over a few of the responsibilities of what we do as an ADAMH board. And really what we're there to do, we do not provide direct services. So what we do is we accomplish the work of service provision through contracting with local agencies to help provide different services, whether it be substance use disorder treatment, mental health treatment, prevention, just a number of services that we do fund, but we do not actually provide them directly. So those are important. It's important to understand that we are not a service provider. But one of the things that, and I'm not going to read through this whole list, but one of the things I do want to talk about that we do take really seriously is protecting the personal liberty of mentally ill persons so that they may be treated in the least restrictive environment. And basically what that means is we have this community system that we've put in place, but we also recognize that there are sometimes circumstances where people are having issues and do have to have their civil liberties suspended for at least a period of time so they can be maintained safely and evaluated, and also public safety is maintained as well. But the other things that we do, and we can actually go on to the next slide from here, Matt, is we work and develop that quality network of services, try to develop as much as we can based on the resources that we have, a really comprehensive system of care, and also following the rules that are promulgated by our state department, which is the Ohio Department of Mental Health and Addiction Services as well. So the other thing that I would want to touch on just real quickly before we leave this is the last bullet there, or triangle, I guess, as it is, promoting the participation of individuals receiving mental health and addiction services in the planning, delivery, and evaluation of those services. So we feel it's really important for having people, whether they be family members, direct service recipients, into and hearing their feedback. So getting that feedback loop of the individuals who actually receive the services to make sure that it's meeting their needs to the greatest extent possible. So we can move on from there, but I did want to just touch on some of the things that we do at ADAMH. I mentioned the Department of Mental Health and Addiction Services. We have to turn in to them a community plan where we identify our basically our focus areas, and we participate with the community health assessment process and community health improvement, the community health assessment and community health improvement plan with the Department of Health, with the hospitals, and that is actually in both counties. We actually help fund and participate in those. And along with that, working with our local partners and stakeholders, we come up with priorities. And so these are the priorities that we identified in our current community plan. We look at trauma-informed approaches and resiliency, prevention, services to criminal justice, and recovery support services. And so one of the things that is not specifically listed on here as a priority area, but is a service priority for us, is suicide prevention. So we'll talk a little bit more about that as we get into the presentation. But we can go ahead and move forward from there. This slide is from NAMI, the National Alliance on Mental Illness, and this shows graphically about just the number of people who are impacted by mental health or mental illness in a given year. It's 1 in 5 adults, so it's very common. And in terms of a serious mental illness, so that would be looking at more things like serious depression, also schizophrenia and other related disorders, that affects about 1 in 25, but still 10 million adults. And the last one, I think, on the bottom of the slide is interesting in that roughly a half of all mental illness begins by the age of 14 and 3/4 by the age of 24. So as you think about that continuum of services, and I'm going to talk about a couple of things when I wrap up about some kind of directions that I see the system moving in the future, this will come back into play because I do have some thoughts about the healthcare system and potential integration with behavioral health. So I'll touch on that briefly at the very end. So what is a mental illness? So we have a definition here. It's basically a diagnosable condition, just like any other condition that you have, whether it's diabetes, COPD, high blood pressure, but it affects the person's ability to think, their emotional state, and how they act, their behavior. and it disrupts their ability to work, which is obviously very important to this particular audience as well, carry out daily activities, and really engage in meaningful and satisfying relationships. And that ties into well-being and stability in the community, as well as having those connections to people and being able to be in relationships as well. So on the next slide, this is a little bit, I like to have this one in, but graphically every time I see it, I'm like, why do I have this slide in there? But anyway, there is a lot of text on this, but what I like about it is that it really kind of goes through and helps people understand what might be going on behind the scenes. You know, you might see people who you think are lazy, they're not able to get out of bed, they may not be able to pay attention, they may just be rude to you. And that could be someone who's just rude, or you know, someone who may need or may have another issue going on. But what could be happening is that there could be just fatigue, and we do know from people who suffer from chronic depression, there is that just sense of exhaustion and fatigue that just is so hard to overcome. And it's hard for individuals who struggle with that, and especially those who aren't getting treatment, who, you know, just really have, it's almost disabling to a certain extent. But also constant worrying, numbness is another thing. Brain fog is another issue that does come up with chronic depression and other conditions as well. But I do like this one again, because I do think it's a good contrast between what people you may be thinking is going on and what might actually be going on behind the scenes. But moving on to the next slide. So it's the mental health condition, whatever the diagnosable condition is, it's not the result of one thing, not the result of one event. And certainly there's genetics, there's environment, and there's other things that go into a mental health condition. And it could be stressful jobs, stressful home life, and also trauma. And we did talk about trauma at the beginning in terms of being one of our kind of priorities that we're going to be focusing on. But certainly having something like being a victim of a crime, you know, having being, maybe if there's a veteran that's working for you, and that veteran has experienced post-traumatic stress because of the work that they've done while they were serving our country. That's something to be aware of as well. But this is basically saying that it's not, or rarely is it, one thing that causes the mental health condition. It's a combination of many things. So I'll go through, and we can go ahead and move forward to the next one, Matt. And so this kind of gives a nice breakdown of just the prevalence of mental illness by diagnosis. And this one I think is I know initially when I first started doing some of these more detailed talks, I was really surprised by the percentages about how much anxiety really was really the biggest category. And sometimes you think about depression and bipolar and schizophrenia. And I think this kind of feeds into one of the common misconceptions about mental illness, is that they're very common, but it's not the more serious mental illnesses that are frequently the most diagnosed. Not everyone has schizophrenia. Not everyone has bipolar. Not everyone has serious depression. It's really looking more at that general anxiety along with depression and some of the other things. And one of the things that's interesting as well, too, is how substance use can sometimes tie into these diagnoses as well. But I like that slide. It's a good one to kind of give a spread of what that looks like. But we can move on. Again, anxiety, that's the most common. It affects an estimated over 40 million adults in the US. And we have the general types of anxiety disorders that are listed there. We have the generalized anxiety disorder, social anxiety disorder, panic disorder, and other phobias. And again, this is a big one. This is going to be the most broadly diagnosed category. And the other thing to point out too is that these are not mutually exclusive. So it's not uncommon for people to have both anxiety and depression. So a lot of times you will see a lot of co-occurring even within mental health conditions with those disorders. So the next one we'll look at is depression. And this is one that I think a lot of people do think of when we think of mental health, and understandably so. It affects about 7% of the population, as we talked about earlier. And depression is treatable, but sometimes it is challenging to find the right blend of medication and treatment. And I think that's true for all mental health conditions, but especially depression. Some of the common symptoms, I'm not going to read through all of these, but you could see changes in sleep or appetite, inability to concentrate, again, having that fatigue, that loss of energy, and the inability to function. Also losing interest in activities. That's another key thing that we'll talk about a little bit more later. Hopelessness is another one, and then closing with suicidal thoughts. And again, we'll touch on these a little bit more as we move forward. But the next one is PTSD, or post-traumatic stress disorder. And this is one that does affect a lot of different folks in a lot of different ways. And so a traumatic event could be something like an accident, could be, again, the military, having served in a theater of combat, could be a natural disaster, could be something where we have a severe thunderstorm or tornado that rolls through and causes storm damage to a home, or maybe a loss of a home. Could be a fire or something like that. So it's something along those lines that really has a significant and lasting effect on the person's mental health. And the other thing to keep in mind with PTSD is that in some cases there may be shorter term symptoms, but in many cases there will be longer term symptoms that do evolve from that. And the other thing that's important to understand too is with PTSD, they do frequently coexist with other conditions. We mentioned the mental health conditions that we're touching on earlier, but also substance use. And a lot of times it's not, I won't say a lot of times, but it's not uncommon, I would say, to have there be that substance use that maybe sometimes people use to kind of maybe help themselves relax or feel, less intense feelings because of that. And so we want to be mindful of someone who maybe have PTSD, also monitoring their alcohol consumption and things like that, just to make sure that we're tracking on that particular issue. So I think the next one we have is eating disorders. This is one that has kind of come up a little bit more recently in our system anyway. And there's a couple different ones, and I'm not going to read through all of the text here, but it's something that is going to affect not a huge percentage of population, but it's one of those populations that we want to be mindful of, especially in the younger population. We do see it a little bit more frequently there, but that's not to say that it's mutually exclusive to that category. We do see that can occur in people of all ages. But you see the different types of disorders. You have anorexia, bulimia, and then also binge eating. So I won't touch on those in a lot of detail, but I just wanted to note that those are very real, and we have been seeing a little bit more of that recently. Schizophrenia is basically, this is one of the more serious mental illnesses, and it really affects with the person's ability to think clearly, to be able to have normal emotions that are more level and more normal, relatively speaking. It is a very complex and a long-term medical illness. It doesn't affect as many people as folks might think. I think there's maybe this general misconception that everybody who has a mental health or mental illness is going to experience schizophrenia. That's not the case. The other thing about schizophrenia is that for men, if you're going to see that, it typically begins to emerge in the early 20s. And then for women, it's the late 20s to early 30s. So if someone's going to start to exhibit symptoms of schizophrenia, that would be the ballpark that we would be looking at. But again, as the last little triangle indicates, that's not going to say that if it doesn't happen in those timeframes, that it's not going to happen at all. That's just really a ballpark. Dual diagnosis basically refers to when someone has a diagnosis that is both mental health and addiction related. And this is something that is again, not something that's uncommon. It does affect over 9 million people based on 2018 estimates. And the one thing that's important to understand with this is that either the substance use or the mental health or mental illness can develop first. That doesn't mean that they will always develop together, but there is this kind of, as I mentioned with the PTSD slide, there is this, I think, phenomenon where people will use, whether it's alcohol or another, whether it's a prescription medication or something along those lines, to really help treat something that may be more of a mental health symptom that they're experiencing, as opposed to having actual mental health medication for that. So, and we do also know that the alcohol sales were up very high during COVID. And so that's something that we are definitely keeping an eye on from our system as well. So in summary, mental illnesses are diseases of the brain. They affect mood, thought, behavior, and judgment. Medication and therapy do work, but they are best when they're combined together, and it takes time. It takes time to get medication dosages correctly. It takes time frequently for individuals to find a good connection with a therapist or to find someone who can, really relate to them and understand. But we do want to leave with the thought that mental illnesses definitely are treatable and recovery is possible. So I wanted to shift a little bit and focus more specifically in the time that I have left on suicide and suicide prevention. And we do have the note here from Dr. Horry, who's the director of the CDC. And she had indicated that the rates have been concerning. I don't have this slide in the slide deck currently, but one of the presentations I've done on this in previous iterations has shown that all states, I believe, except for one, so 49 of the 50 had increases in suicide rates between 1999 and 2016. So it's a significant problem, and it's something that we need to continue to focus on, especially in light of coming out of the COVID world where we were isolated and not able to have the connections that we were used to having. So here is the latest and greatest from CDC. Basically, we were looking at a 39% or 33% increase, and so this extends beyond what I had just mentioned a moment ago from 99 to 2016, where all states saw that increase. My sense is that those numbers will go up once 2020 is released, unfortunately. And I think the numbers across the board are going to not look great, whether we're talking about suicide or overdose deaths. I think that 2020 is going to be a tough year for both of those. But specifically for suicide, it was responsible for nearly 50,000 deaths in 2019, which is about one death every 11. I believe that says, hold on just a second here, 11 minutes again. So a very high rate. And the other thing that's concerning is just about suicidal ideation. So in the last bullet there, we look at the number that are seriously thinking about suicide, and there's a slide later that I'll touch on that has a little bit more detail on that. But we can move on to the next one. This is again giving a little bit more information. So it's the second leading cause of death for people ages 10 to 34, and leading cause of death from 34 to 54. And so one of the things I did want to touch on, I've got some maps that I'm going to show here in a few moments that look at both Crawford and, well, actually it's the entire state, but we'll talk specifically about Crawford and Marion, and I have some local rates there. But the other thing that we need to be mindful of is that there is some variation between different groups, whether we're looking at age, race, ethnicity, and other factors. There were also, I think I'm going to go through an example, hopefully here, time permitting, that talks about just exposure to stress, how that has been traumatic and has led to some concerns in the healthcare world. So, but again, it's context specific, but it does, the data does suggest that there are certain groups that do have higher rates of suicide, including veterans, people who are working in certain industries like mining, construction. We've also had some concerns coming out of Crawford County in the manufacturing sector as well. So we can move on from there. These are the 12 warning signs. Again, these can exist in more than one. And so one of the things I'm going to talk about here momentarily is a new suicide prevention training, or newer to us, I will say, which is called QPR, or Question, Persuade, Refer. And so how this could play out in the workplace is that if you were to hear a coworker or an employee start to talk about making comments about some of these things, like being a burden, giving things away, feeling like they're trapped, or making overt plans, those would be definitely some warning signs that you would want to take note of and make sure that kind is in a safe place, and that you can assure that they're receiving the care that they need as best you can. But those are kind of the broad 12 categories that we see. And then moving forward, what we want to talk about on the next slide is, these are just some general steps. We'll talk a little bit more about some more specifics, but basically ask the question. I think there's a lot of concerns about if you're going to ask someone, are you thinking about suicide? Are you thinking about hurting yourself? There's a thought that plants a seed. The data does not suggest that. In fact, what that does is it opens the chance to have a dialogue. And a lot of times with suicide, there's this feeling of lack of connection, or that people are abandoned or all alone. And so this really gives an opportunity to have that dialogue and to really help them feel that sense of connection that may be lacking. You also want to make sure that they're safe, be there for them, making sure that they're connecting to the services as best you can, in whatever role we may be looking at. And then following up. I think that piece of, there may be a thought of, well, we helped get the person to the ED, that's all we can do. I think it goes a long way to, again, having that sense of connection and also compassion and empathy to making sure there's a follow-up conversation, if you can have that, to make sure that the person is doing okay, or if there's ongoing issues that may need to still be monitored. So some local trends and data, we'll kind of jump into this a little bit. So in Crawford County, the Crawford County Public Health Department does a very nice report in terms of trends. So I would encourage you, if you're interested. That was in 2018, so that's going on about 3 years ago. The other thing that I refer to in the maps that we'll look at momentarily is this was a report that was done by the Ohio Alliance for Innovation in Population Health. And that's kind of a group of Ohio universities, one being Ohio University, but a group of other universities in Ohio that kind of study these trends. And so I think the next set of slides may have some maps that we can talk through. So here's, so this is just a suicide rate per 100,000. And so you see Crawford and Marion are in that just under 13% is the rate there. And obviously this is a slide that if there's a rate at all and it's not a zero, it's concerning. So, we can look at other counties and say, well, they have a higher rate, but it's not really meant to be that way, I guess is how I would say that. And so the other thing I did want to point out is I did have, if I can navigate this, bear with me just a moment. I did have an update for 2019 data. And the rates are approximately the same. So even though this slide only goes through 2017, the data that would include up to 2019 basically has both Crawford and Marion counties at approximately the same rate. I guess the good news is that it didn't increase. The bad news is that we still have work to do. And that's part of what we wanted to talk to you about today. I think the next slide that we have is another map. And this one is a very powerful slide because it talks about, and I don't have an update for 2019, but I think this kind of stands on its own. So if you were to just look at Crawford and Marion County residents, so if you looked at death by suicide and consider the concept of years of life lost. So this is taking into account the time or the age that the person would have been when they died by suicide and the average life expectancy. There's a 5,000 year total between Crawford and Marion counties. And if you think about the impact that has on families and communities and employers, that's a significant number. And so that's definitely a number that we want to focus on with our efforts to try to make that number as small as we can. So I did want to talk about some specific programs. Signs of Suicide is a school-based program. It's universal. We offer it in the schools. I refer to CCS there in that second slide. That's actually community counseling in Crawford County, but Marion Area Counseling Center in Marion also provides that as well. And it's in Marion, so both Crawford and Marion counties. And it's designed to do middle school and high school. It's done twice a year. So we work closely with the schools to have a screening, and depending on how the students would answer the screening, then that would determine what the next step would be. If they did not identify significant issues that warranted further attention, they would get education that they could be shared at home. If they came out at a higher rate, then they would either have intervention from the school and or professional intervention from one of the agencies, whether it be Marion Area Counseling Center or community counseling in Crawford County. But SOS is an evidence-based program. We're very proud to have had that for many years in our communities. I think on the next slide, it touches on just some of the elements of the programming or the goals. And obviously, you want to decrease suicide and suicide attempts by increasing student knowledge. We want to encourage personal help seeking or help seeking on behalf of another student or friend, reducing the overall stigma around mental illness and acknowledge the importance of getting help. and engaging parents and school staff as partners through gatekeeper education. We'll talk about another gatekeeper program in just a moment. But also encouraging schools to develop community-based partnerships to support community mental health. And again, it's about having that conversation and talking openly about mental health and other issues. And Laura from BWC mentions the stigma that exists, and that's still very real. So we do have to acknowledge that and make sure that that we are thinking about that and normalizing the ability to have those conversations openly. We also have provided mental health first aid. Some of you may have taken mental health first aid through the chamber. April Smith, prior to her leaving MAC, Marion Area Counseling Center, had done mental health first aid. She's still in the community, but no longer with MAC, and so we do occasionally work with April. But mental health first aid is an 8-hour course. It does have some pre-work that goes with us, but it was really kind of designed with the whole concept of, we have first aid and this kind of concept of helping someone who may have received an injury, a physical injury or something like that. So what can we do to help someone who may be suffering from a mental injury or have a mental health issue? And so it's something that's grown. And I think with the advent of technology and with virtual meetings, we have worked with the providers. This is a program that it is copyrighted, so we do have to pay for it when we do offer it. So, but it's a very good program, and we'll kind of go through a little bit of what's included in the next slide and see what it covers, common signs and symptoms. So some of the things that we've talked about only in more detail of mental illness, of substance abuse, interacting with people who are in crisis and how to connect them with help. The other thing that was new, this should say newer instead of new at this point, but it's also how to administer naloxone in the event of an opioid overdose. And so we're not going to spend a lot of time talking about SUD, substance use disorders, or things like that. But one of the things that we do know, even though the drug trends have changed and there's a lot less opiate-related substances, illicit substances in the community, what we have seen is that the other illicit substances that are coming in are sometimes contacted with other opiate or synthetic opiates. You may have heard fentanyl. Fentanyl is a very powerful synthetic opiate that's a painkiller. But it's also used as a cutting agent for a lot of different substances. So what you're having is a lot of cross-contamination with people who are who may be using illicit drugs, but because they don't know that they've been in contact with the fentanyl, they're overdosing and dying. In a lot of cases, that's something that they didn't expect to deal with. So that's part of what mental health first aid covers. Who should take it? I think it's really across the board. I would say employers definitely at the top of the list, law enforcement, first responders, faith leaders. That's another big one that I think would be important to have, and just really anyone who's a caring community member who might be interested in that, who might be a family member or might have other loved ones. We also have a specific youth mental health first aid program. We do offer that locally through Marion Crawford prevention programs. So if that's something that you're interested in, please let me know and I can connect you with the good folks at Marion Crawford prevention programs. But that's a very good program as well. Just some slight variations from the regular standard mental health first aid template to help tailor it to youth needs. And so I think I have maybe just one more on the mental health first aid. This is the action plan. So the acronym is ALGE: approach, listen, give, encourage, encourage. So it's basically making yourself available and asking specific questions, not being afraid to do that. Listen without judging. I think a lot of times, myself included, I want to jump to the solution, but a lot of times what's better to do is to just listen, let the person talk through what the issues are, and then just be reassuring and give them the information to help make sure that they get to where they need to be, and to also make sure that you're encouraging not just professional help, but also other support, self-help or other support strategies. And I think from there we move on to a couple other, this is the Working Minds program is another one that's kind of coordinated with Marion Crawford Prevention Program. And this is a specific program that we've been trying to get off the ground. And so if anyone's interested in Working Minds, again, this talks about the impact of death by suicide and the potential impact on employment, places of employment. And so we do have that available as well if folks would be interested in having a dialogue with Christy Eckert, who works at Marion Crawford Prevention Program. She is our contact on that one. Again, a shorter training, 2 hours, as opposed to the mental health first aid, which is 8 hours. And I think the next one that we have, good, I did the order correctly. Question, Persuade, Refer. This is QPR. So this is a relatively new training to us. This is a gatekeeper training, and I'll on the next slide, which we don't have to go to right now, I'll describe what a gatekeeper is and how that works out. But the nice thing about QPR is it's only an hour long. So, you're not going to really master much of anything in an hour, but this does do a nice job in this training of helping go through these different steps of questioning, persuading, and referring, and basically learning more about the keys to preventing suicide, what some of the common causes so some of the warning signs, again, that we touched on earlier, those would be consistent with these types of things. And then also how to connect to somebody in crisis. And so you'll notice on this slide and then the next slide where I talk a little bit about gatekeepers, down at the bottom there's the reference to the QPR Institute. So if you're interested, I would encourage you to go to the website, get the information. We do also offer this training locally. It can be scheduled, and we have some different training partners that can offer that. But just to talk a little bit more specifically on the gatekeeper piece, on the next slide, we have the definition here. So this actually came about 20 years ago. And so it came out of the Surgeon General's strategy for suicide prevention. And it's someone who's in a position to recognize a crisis and the warning signs and potentially intervene with someone who may be contemplating suicide. So the list of who could be a gatekeeper is pretty large. It includes supervisors, foremen. You can see a lot of other opportunities there. So again, the nice thing about QPR is that it's not a lot of time commitment. I think it's a good training. I've gone through it myself. When we were in the midst of COVID, we worked with the Ohio Suicide Prevention Foundation, and they actually did some training for us online and specifically targeted some of the correctional facilities that are here locally to make sure that those individuals were mindful of those things with each other and with the people that they were around as well, just due to the heightened stress that they were under at that point in time. So moving on from there, I'm not going to spend a lot of time talking about the impact of COVID because I think we all know that pretty well. The one thing that I will touch on is I do think there was this sense of social isolation and disruption, and the inability, especially in our world around addiction and mental health, to have that type of face-to-face connection. And a lot of the support groups that we went through, like 12-step groups like AA and NA, had to go virtual. Our local NAMI affiliate, which is the National Alliance on Mental Illness, there were programs that they were not able to deliver in person to help support family members with mental health issues. So it caused a lot of disruption in programming and the services, the way that they were delivered. And I think that we've had a lot of learning. There are some things I think we'll continue to be offering virtually, but I think on the whole, there's this, I think, thought of it's better to be back together as long as we can ensure safety and the health of those individuals that we come in contact with. So moving forward from there, in terms of what's at risk, depression, anxiety, substance use disorder, and PTSD, some of the things that we've talked about earlier. Also worsening conditions. So I talked earlier about alcohol sales increasing, and certainly this is not anything to say that people aren't able to consume alcohol. It's a legal thing, so that's certainly allowable. But the concern would be is how is it being used and how much is being used, and is there becoming more of a dependency and in terms of the thinking of how it has to be used. But that's something that was definitely at play, and also a complete relapse. We had individuals who were very concerned about, who may have had years and years of sobriety even, or months or weeks or days. So any type of relapse there would have been very different during the shutdown. And I'm glad that we're kind of moving out of that and finding that we can continue to support each other as we had before. Moving forward from there, we talked about, again, distress. So I'm not going to focus a lot on that, but clearly there was a lot of economic hardships, and we're still kind of seeing, I think, the fallout from that, and I think we'll see it for some time to come. But again, we've seen kind of the productivity issue, increased healthcare costs, higher mortality. And we do also, have this figure from the World Health Organization about just the impression or the impact in terms of the global economy that depression and anxiety have, those two leading disorders that we talked about earlier in terms of lost productivity overall. Moving on from there, this is, I actually highlighted a few of these things in my intro, so I'm not going to spend a lot of time on this. This would have been the description for the presentation that Matt read earlier. This is the 40% have reported adverse mental health conditions. And again, who was more at risk? Younger adults, racial ethnic minorities, essential workers. I'm going to touch on essential workers a little bit more here in just a moment. And then specifically, you had the 31% of symptoms for anxiety or depression, 26% with trauma or stress-related disorders related to COVID-19. And again, this goes into substance use. 13% reported having started or increased consumption, which is concerning. And then lastly, 11% seriously considered suicide. So that's the suicidal ideation piece that I talked about earlier that we've been so concerned about. So that's just a quick flyover of some of the survey data that we saw coming out of that. What can employers do? So obviously lead, we want to provide leadership, have effective communication, adapt to change, and double down on access. And just some side points to this, I think that we want to make sure that it's normalized to talk openly about mental health. And again, thinking about how to be, making sure resources are available for employees should they need them. The other thing is policies, practices, and expected, getting cut off on my screen here. Oh, just a second. Expectations. Sorry about that. I couldn't see that word. But also providing prevention, support, EAP, mental health, and SUD care. So I want to talk a little bit about the policies, practices, expectations. And if we could go ahead and go to the next slide, please, Matt. So what we knew from healthcare is that healthcare, our essential workers, our frontline workers for healthcare, were really at elevated risk for experiencing trauma during the height of the pandemic. And so telehealth did a lot of great work. Telehealth made services available, but there were certainly services, and certainly there were emergency services that had to be provided. And so individuals were definitely hospitalized. And so that kind of built up and really kind of provided an elevated sense of risk for the healthcare professionals. What we also know is that the most effective way leaders can help is by helping colleagues being able to connect with other or peers, basically, in proximity to a traumatic event by utilizing a structured conversation. And be happy to do some additional resource digging and share the specifics about how those structured conversations are done. But basically, the thought is that is there a way within the work that we're doing, whether it be healthcare, manufacturing, whatever the case may be, to thinking about how the workflows exist currently, how they had to be modified perhaps for COVID, and is there a way that we can build in some workarounds so that we can allow, as in the case here with the healthcare example, individuals to have this time to process. And obviously time is money, and we want to be very respectful of that, but just some thinking about, how are there things that we've learned through COVID from a policy and procedure and workflow perspective that we might be able to capitalize on. And then lastly, this is specifically around healthcare, but I think there's also some need to think about from the administrative perspective on the healthcare side, is there a way to help provide logistical support to clinical providers to really enhance their ability to provide services and focus on that and reduce the prospects of potential burnout. So those are just a couple examples that I wanted to, or an example from healthcare that I wanted to share as kind of a more tangible way that employers can help. Again, more ideas, sharing signs of common mental health conditions, promote access to care. Promoting mindfulness is a big thing now, and we certainly have done some trainings on mindfulness. So if there would be interest, either with working with the chamber as a whole or some different arms of the group, I'd be happy to talk to Matt and others about that. Promoting resiliency and also employee resource groups. So individual groups within agencies that can help support each other and help bring additional resources in to the business as well. So I think I'm getting close to the end of my time, and I want to be mindful of folks. So I'm going to run through these last few slides really quickly. Building resilience, we talk about trauma, but we're starting to talk more about how to build resilience. And so that's really, what do we do to recover and grow in the face of trauma and help build those resilient skills. So those are things that we're going to be working on. And this is not something, I think sometimes in my career, when I hear resilience, I think of that often being oriented to younger people, teens, young adults, but we also need to have those skills as adults as well. And it has both physical and mental aspects as well. So here's some resources, local resources. The one thing that I don't spend a lot of time, and I actually completely forgot to mention this, but we're getting ready to have a new National Suicide Prevention Lifeline. So we have 911, we're getting ready to have 988. And so that's going to be coming online within the year, within 1 year, I would say. And so that will be around this time in 2022, that will be online, if not sooner. We also have something, currently have the National Suicide Prevention Lifeline. We have our crisis text line, which is available by texting 4HOPE to 741-741. I also wanted to mention, we have Pathways of Central Ohio who took over Careline. Some of you may remember, and that's actually the same number, the 740-383-2273. That's the same Careline number, and so we do have a new vendor for that, but then Pathways also has an 800 number. And if you've noticed our billboards that were more specifically around addiction, that's the 800 number that we do have on our billboards. You may have seen those out on Center Street, further east, and also in Crawford County as well. We also have kind of our traditional partner agencies in Marion County, our MAC, Maryhaven, and Marion Crawford Prevention Programs. But I do want to highlight on the next slide that we do have a lot of new agencies. And I apologize for I just have noticed this as I've been talking, the capitalization on these is driving the OCD part of me a little crazy. So I do apologize I didn't get all the caps. But anyway, most of these are in Marion County. A few of them are in Crawford. A New Day is in Crawford. Family Life is in Crawford. Of Affinity are in Marion. And so these are some new faces in town. We actually, as a board, are going to be providing some funding to some of these providers that applied for board funding as well. So we'll have more information to come on that in the near future. I think the last couple things, we had some national resources. We have National Institute for Mental Health and Drug Abuse. If you're not familiar with the NAMI website, National Alliance on Mental Illness, I would definitely encourage you to go there and check out. They've got a lot of good resources and support for family members. And that's really what NAMI is about, is support for family members who have mental health issues. And then there's also the Mental Health First Aid website as well. And I think, so let me, if we could go ahead and just do the next slide, Matt. So I did want to just mention, I think the impact of COVID is going to be felt for a long time. While we say that 1 in 5 Americans have a mental health issue, I think all of us experienced distress during the pandemic. And so I think that's had a significant impact on our delivery of services. In the behavioral health world, we've had Medicaid changes with the Medicaid program. And so I won't go into a lot of detail there, but it's been significant and challenging for our providers. For as far as workforce goes, we do have challenges as well around individuals who are coming in, social workers, professional counselors, physicians. But one of the things I did want to touch on that I do think we're going to have a reckoning on fairly soon is this notion of integration with primary health care. And so currently we've had this system of community behavioral health that has existed outside of healthcare by and large. But whether it's integrating behavioral health into primary care or integrating primary care into behavioral health, I think that's something that's going to be on the horizon very soon for our system. And then lastly, just some thoughts around specialized services for youth, peers, and inpatient services. So inpatient services would be like a higher level where someone would go to a program or rehab, if that might be the appropriate term, finding places for persons in recovery to help provide feedback and services as well, and then how we help our young people who have serious issues as well. And then I think lastly, the only thing I want to close with is, first of all, thank you for your time. I appreciate everyone, and I appreciate the invite for this. I did want to mention at the very bottom, if you've not been to our website recently, we updated our website a while ago, And so it's got a lot of different look. I think it's got a refreshed look and a lot of different resources on it. So I would encourage you to go out there if you have questions or want to chat. Otherwise, feel free to call me on my cell. And again, I thank you all for your time.
Couldn't find my unmute button. Brad, thank you so much again. Great presentation. Some really awesome information about a very difficult topic, and some great links, it looks like, that we'll of course share after the presentation's over, links to all the different resources that were mentioned. And of course the slides themselves, which will have the links built into them as well, will be shared after this recording is finished. So again, thank you to Brad. Any other questions for Brad before we end today? I don't see anything in the chat. Actually, I don't even know if I have the chat. I'm gonna stop sharing here just in case. Nope, okay, I don't see anything in the chat. Last call. All right, well, thank you again, Brad, and thank you again, Laura and Thad, for giving those updates. And we will see, you'll see notice about the Lacey Award and that being open and accessible for the applications here by the end of this week. And of course, you'll receive notices for next month's meeting. Thank you again to Brad, and have a great rest of the day. Thank you so much.